I think we are live. Very good evening to all of you who are with us today to episode 2 of Think Like a Mentor. I am Ravi from DocTutorials and I bring to you our very own Dr. Nileshraj, the magician of pharmacology. And I think, I have seen a lot of faculty members, but very few as witty as Dr. Nileshraj is in terms of the one-liners or the jokes that he passes in between. Yeah, and that is how he makes his content very engaging also. Today, we have him with us, not for a purely academic session, but it is more of a strategy kind of a session where he is going to take you through what goes into a mentor's mind, a faculty's mind, a question paper setter's mind when he is looking at a question and the options following it. So, Dr. Nilesh Raj is going to take a 15-minute mini test that is available on DocTutorials when the timer is live. So in the exam pressure, in the timer pressure, how is it that the topper thinks? Right? That is what we will be. How is it that a mentor thinks? That is what we will be trying to primarily communicate through this. And Dr. Nilesh, very good evening to you. I welcome you to this to your show now, and the floor is all yours, sir.
Thank you, Ravi Garu. I hope my audio and video are clear. I hope my audio and video are clear.
Yes, sir, you are audible and visible clearly.
Yes, but yeah, okay. Thank you so much. Thank you, Ravi Garu, and I very much sincerely thank Dr. Trills for putting up in this new kind of a session, which I feel like is more of what to say, a test for us than for the students. But it's actually good to have a good interaction with the students regarding, because this is something which usually students will not be able to look at. Students will not be able to look at how to solve the questions, especially those newbies who are trying to attend the exams within like few months of time. When they go for the short test, when they go for the mini test, they should know how to approach a question and how to read a particular question. Before diving into this, guys, I'm going to be taking a mini test, and that mini test, I don't even know how much question it contains. So based on that questions, I'm going to be coming up with that. We're going to be solving that question together. And I'm going to be talking out loud, like what exactly I'm thinking when looking at that question. The thought blocks which every student has, even every individual guys who are looking at the question will also be having it. So those thought blocks, how to proceed with that, how to overcome that. And before going into that, every time before the exams, I will be having certain basic rules. One particular rule, one first rule to be remembered is, I will know how many questions I'm going to be attending. Point number one. Number two, initially, first of all, I will go through all the one-liner questions, all the recall-based questions. Every question is going to be of three major subtypes. Either a question can be a recall-based, or it's a problem-solving based, or it's a comprehension analysis-based. Most of our NEET PG exams questions are either of recall based or problem solving based. Comprehension analysis is not usually our cup of tea as per NEET PG or INC exams is concerned. So what I'll be having certain rules, and that rule is, first I will go through question number one. If it is a recall based, just one liner question, I will attempt it. I will go to the second question. If it is a longer question, I will not attempt it on the first time, right? I will just mark it for later. I will move on to the next question. I will finish off all the recall based, because that's the usual rule which I do during solving the questions. Why? Because recall based are only have two different options. Either you know the answer or you don't know the answer. That's it. So there is no thoughts of like thinking of it, no, like coming up with some clues or finding some other things, joining all the dots. There is no points in it. So whenever I come across these questions, I will go through all the recall based questions and I will see how many questions I have not answered. Every sections in your main exams in your NEET PG, there are going to be 40 questions in that section, sorry. And within those 40 questions, I plan to leave up to a maximum of three, not more than that. So I'll be going through all the recall questions. You know or you don't know, that's it. You cannot attempt it. If you attempt it, there is more chance that you might put up in wrongly. So I will go through all the recall based questions and I will try to answer maximum out of those questions. After that, I will come towards those bigger questions. When I come towards those bigger questions, which contains 3 or 4 lines or even 5 lines in that, I will first of all read the lead in statement, the last line which is present in that question. After looking at that question, I will go through the options. I will try to narrow down which subject this question belongs to. Of course, in this mini test which you're looking at here, that's going to be your pharmacology. But in your main exams or in your mock tests, we don't know which subject the question belongs to. First of all, I will try to find out which subject this question belongs to. The second one, I will try to find out at least which system this question belongs to, like CBS or CNS or ANS or autocoids, any topic which it belongs, or antibiotics, anything is going to be. If I could narrow down any of these two different, either is going to be subject or a system, then I will attempt that question. Right? If I couldn't narrow down any of those both different ones, I will just mark it for later and I will move on to the next question, because I don't want to waste time after starting to read from a 45-year-old male, for example, and I just go through this whole theory. At last, I come to know that that question is from a topic which I've never learned in my life. I don't want to waste around 40 to 45 seconds in just reading that question. So I will always go through the last line. I will go through the options. I will try to narrow down the system, narrow down the subject. I couldn't do that. I will mark it for later and I will just move on to the next question. After coming up towards all the questions, I will come back to those. Clear? With this basic rules which I have, let's start with the discussion, my dears. Let's start with not the discussion. Let's start with the test at present. So I think you can see it, guys. You can see it in the screen. I have opened the DocTutorials app, and we have the home here. We have the NEET PG, MBBS curriculum, and FMG, NEET SSPG residency. Everything, every individual things are there. I have clicked on to NEET PG. And within that, we have QBank series. As we can see, we have QBank, we have test series, we have videos, analytics. I'm going to be clicking on test series. Within test series, we have multiple tests, multiple areas, which includes your leaderboard. We have grand tests, mini tests, subject test, system-based, and T&D, test and discussions. I'm going to be going through the mini tests. Within mini tests, we have multiple subjects over here. We have anat, physio, patho, pharmac, all the subjects are there. Because God forbid, I'm a pharmacologist. I'm going to be clicking on pharmacology. So within pharmacology, we have multiple mini tests. Mini test 6, 5, 4, 3, 2, 1. Let's click on to mini test 1. I'm going to be going through the live things of mini tests 1, which contains, I think, 25 questions. Yes, it contains 25 questions, my dears. I'm going to be clicking on what are the topics which are included. Mini test 1, we have basic principles of pharmacology, which is general pharmac. Then we have autonomic drugs, autocoids, and GIT. Okay. So these are the different, just give me a minute. Okay. So these are the different topics with which this mini test is going to be hopping on with. Okay, now we're going to be clicking on this test. If you guys are watching this video, please open the DocTutorials app and please go to this same sequence, open that particular test and start solving the questions along with me. Don't worry, consider this 25 questions as how I'm going to be approaching that. You're going to be utilizing those questions. Don't worry. Even if, sir, I have already done that test, don't worry. You just click on that, click on solve again. You can go to and click on solve again and try to solve it in a different perspective from how I'm going to be looking at it. I'm not going to be saying that I'm the thing with the way which I'm thinking is the exact perfect right one. No, not like that. Because we have lots of difference between you and me, because I'm purely a pharmacologist, guys, right? So we just need to know how, especially a mentor like me, who's a pharmacologist, how I'm going to be approaching that question after looking to multiple MCQs, because we have designed multiple choice questions. So we know how a question is actually been designed. That's why our approach is going to be a little bit different. Okay, let's start with the mini test, guys. Let's start with the mini test and basic principles of pharmacology mini test 1. 30 minutes is the time which is given. Totally 25 questions are there. 30 minutes is there. Usually, I will be having that time limit of around 20 minutes. Usually, for example, if 30 minutes is the test, 20 minutes will be my maximum time. Within that, I have to complete most of the questions. That's how my thought is going to be. Okay, these are the basic explanations, like how, what are the different questions which are attempted, and what are the questions marked for review, and how it is going to be looking like, and questions attempted and marked for review, and questions which are not visited is going to be looking like that, and questions skipped, it's going to be there in red. And these are the basic rules which I think most of the like questions is going to be having up with. With this, we'll start, guys. Yes, I have read all the instructions. We're going to be starting the test. You also start the test along with me. Okay. We'll start with the first question, guys. Okay. A drug. Okay, this is a one liner. I will try to attempt that question, and also the options are very much smaller. I think it will not take too much amount of my time. I will start with this first line. A drug that binds to a receptor. Okay, I'll just zoom in for your visibility. A drug that binds to a receptor at a site distinct from the active site and alters the affinity of the receptor for the endogenous ligand is called as. Here, the first clincher terminology is a drug that binds to a receptor at a site distant from the active site. It is not an active site, it is an allosteric site. As it is not an active site, as we can know, the competitive antagonist option A is getting ruled out. Inverse agonist, I think it is purely based on drug receptor, yet it might be an answer. Partial agonist, yes, it might be. Allosteric modulator, it also can be. And let's look into the other lines. Alters the affinity of the receptor for the endogenous ligand. Yes, it is binding up with the allosteric site and it is altering the binding site of the endogenous ligand, which is classically the non-competitive inhibitor. Competitives will bind with the active sites, non-competitive will bind with the allosteric site. So the answer for this question, I hope it's going to be allosteric modulator. Okay, here I have no queries, so I will not be marking anything for review. I will move on to the next question. Okay, I will move on to the next question. This is a bigger question, guys. This is a bigger question. I will not waste my time by looking it for it. I will mark for review and move on to the next question. Again, we have a bigger question. Okay, I think I can try it out. Just like 3 lines, no? I will just try it out because options are very much direct. Okay, when you come across this like 3 lines of questions or a little bit more, first of all, I will try to look into what exactly is the last line which is given over here. I'm sorry. What exactly is the last line which is given over here? And that last line is, which of the following would be the effect of this drug on following parameters? Okay. Decrease in Vmax, options, decrease in Vmax, decrease in Km, decrease in both Km and Vmax, no change in the Vmax. Okay, I will go into that. This question is regarding what? This question is regarding general pharmac, enzyme and drug interaction. I have narrowed down to the topic. I have narrowed down to the subject. Now we'll go with the first line. A 56-year-old male patient brought to the ophthalmologist for a checkup and prescribed a newer medicine called Diamox for glaucoma. Diamox is a trade name which should not be used in a question, but of course, we have seen Digene to be used in an INACT exams also. So Diamox is nothing but your acetazolamide. Yes, it's a non-competitive inhibitor of carbonic anhydrase enzyme. Yes, which of the following would be the effect of this drug on following parameters? Non-competitive inhibitor, what exactly is going to be happening to the enzyme? I remember my own that image-based ones, guys. Competitive inhibitor, Km and Vmax. Competitive inhibitor, Km will be increased, Vmax will be unchanged. Whereas non-competitive inhibitor, Km will be unchanged, Vmax is going to be decreased. So non-competitive inhibitor, decrease in Vmax is there in the options. Decrease in Km, no, Km remains unchanged. Decrease in both Km and Vmax, no, that will be there only for uncompetitive inhibitor. No change in the Vmax, which is there in option D. No, guys, Vmax will be decreased. Vmax will not be changed for a competitive inhibitor. So I hope the answer is going to be option A. Good. We'll move to the next question, guys. Yes, it is a one-liner question, and we have smaller options. I will try it out. Natriuretic peptide receptor belongs to which of the following types of receptors? Natriuretic peptide receptor belongs to which of the following types? Okay, so this question is regarding general pharmac. Question is direct. Question is regarding general pharmac, and they have asked. Also, it comes under physiology. This question is about what's the nature of a particular receptor. Whether I know this topic, yes, we have learned this topic. Is it not a G protein coupled receptor? It is not tyrosine kinase. It is not JAK-STAT. It is a ligand-gated guanylyl cyclase receptor. It is a guanylyl cyclase. It is bounded with guanylyl cyclase on the intracellular area. That's the reason why natriuretic peptide is going to be increasing the excretion of sodium and urine. That will happen by guanylyl cyclase, because I also know one more point. Guanylyl cyclase is a vasodilator agent. Okay, with this, I will try to find out that this might be the answer for this question. Okay, we'll move to the next question, a smaller question with a somewhat smaller line. Okay, I will try to use that time. Which of the following statements is false regarding the efficacy and potency of a drug? Efficacy and potency of a drug. So this question is regarding, again, general pharmacology. They're asking about dose response curves. Option A, in a clinical setup, efficacy is more important than potency. But before that, which of the following statements is false regarding the efficacy and potency? Which means I will have that inside my mind that it is a negative phase question. Negative phase question means all of the following is going to be similar except for one. Well, that's what is going to be there in my mind. So this is a negative phase question. Option A, in a clinical setup, efficacy is more important than potency. Yes, because efficacy will decide the drug of choice. So this statement appears like a true statement. Option B, in a log dose response curve, the height of the curve corresponds with the efficacy. Yes, efficacy is the taller the graph, more will be the efficacy. Lefter the graph, more will be the potency. Okay, that appears like a true statement. Option C, ED50 of a drug corresponds to the efficacy. Yes, here is where the wrong option is. This is a false statement because ED50 will explain the potency, guys, whereas efficacy will not be explained by ED50. Okay, we'll just move on to this last option. Drug that produces a similar pharmacological effect can have different levels of efficacy. Yes, of course, efficacy, the level of that responses might be different, but the effect might be same. For example, we have two antihypertensive drugs. One drug will be having more efficacy than the other drug. Well, that's what the statement is. This statement appears like a true statement. For me, I think like option C would be the right option. I'll move to the next question. Proof of concept for a new drug is generally proven in which of the following phase of a clinical trial? This is a one-liner question. I know that proof of concept is going to be there in phase 2 of clinical trials, because phase 1 clinical trial I involve like normal human beings. Phase 2 trials, patients will be involved. As patients are going to be involved, okay, I'm getting an option. Please zoom it. Okay, I have zoomed it, guys. I hope it's okay. Good. Proof of concept for a new drug is generally proven in which of the following phase? Again, phase 1, phase 2, phase 3, and phase 4. Phase 2 is where the patients are going to be involved at first. So I know that for proving a concept of a particular drug, I have to use it in patients. So phase 2 will be the answer for this question. I'm going to be clicking on for that. Okay, so we'll move to the next question, guys. And those students, please open the app and try to do that. It will be useful for you. I will click on the next question. Okay. This is a bigger question, but I think we can answer it because just 3 lines. A 45-year-old male patient was scheduled for surgery. As a part of pre-anesthetic medication, he was administered glycopyrrolate. What is the rationale of giving glycopyrrolate before anesthesia? So this question is regarding an anticholinergic agent which has been given before surgery and before anesthesia. What the use of it? Anticholinergic agents to allay anxiety. For anxiety clearances, we always opt for a benzodiazepine, guys. So option B, to decrease the secretions. Yes, for AT tube placement, we shouldn't have any secretions over there to prevent the aspiration pneumonia from occurring post-op. So for that, I have to give an anticholinergic which will decrease the secretions. This appears like the right option. Option C, as inducing agent, it has got no role in induction of anesthesia. For muscle relaxation, even though it has got milder muscle relaxation, we prefer to give benzodiazepines. So according to me, I think option B is the right option. Okay, we'll move to the next question. This is a bigger question, guys. The question is somewhat more than 3 lines. So here in this, it is a little bit bigger. So I will mark it for review and I will move to the next question. Again, a bigger question. Don't spend a lot of more time. I will not spend more amount of time in going through bigger questions. So I will just mark it for review. Again, a bigger question. I will mark for review. Again, a bigger question. I will mark it for review. A smaller question. I'm going to be trying it out. As I've told during the initiations of the sessions, when I come across a smaller one-liner question, I will just try it out immediately. After that, I will go back and look into those bigger questions. For which of the following reason phenylephrine is an alpha agonist agent, is preferred over other anticholinergic agent as a mydriatic agent in elderly patients? In elderly, why anticholinergics is not preferred? Why phenylephrine is preferred? Okay, let's look into those options. Option A, high ciliary tone in elderly patients. Abruptly wrong, because in elderly patients, ciliary tone is going to be very much weaker, so that's not going to be the option there. Option B, anticholinergics can precipitate glaucoma. Anticholinergics can precipitate glaucoma. Okay, we'll think of it later. I think it might be the answer for it, because anticholinergic agents are mydriatic agents. It might produce angle closure glaucoma, most commonly seen in elderly. Again, we'll look into that, and we'll go to the option C. Phenylephrine can decrease high ciliary tone in elderly patients. Again, high ciliary tone is not seen in elderly patients. It is seen mostly in younger individuals. In children, it is going to be high. All of the above is not going to be the answer. The answer for this question, according to me, is going to be option B, guys. Okay, see, I'm going to be solving that question within that time limit, guys. Within the time limit of, I think, 20 minutes we have. I have to finish it off. So we are going to be doing it together. This is not a test and discussion. Remember, this is not a test and discussion. I'm going to be solving it within that time. I'm just going to be thinking out how I'm going to be coming up with the answer for this question. Next one, we have a bigger question. I will mark it for later. A bigger question, I will mark it for later. Bigger question, a smaller question, I will try it out. A smaller question, I'm going to be trying it out. Which among the following statement is least correct regarding the given NSAIDs? Okay, least correct, which means I'm going to be having up in my mind, this is a negative phase question. All of the three is going to be similar, only one is going to be abnormal. Option A is acetyl salicylic acid is an irreversible inhibitor of cyclooxanase enzyme. According to me, it's a true statement, because yes, it's an irreversible, it's a non-competitive irreversible inhibitor, guys. Option B, aspirin's clearance is independent of plasma concentration. Aspirin comes under the mnemonic 0 watt power FC, which means it follows zero order kinetics. For first order kinetics, I remember FCT is constant, fraction is constant, clearance is constant, and T half is constant. But for zero order kinetics, clearance and T half are not going to be constant. Those are somewhat in relationship with the plasma concentration. But here they have given aspirin's clearance is independent of plasma concentration. I think that this might be the answer, because the question is false. Acetyl salicylic acid reduces in vivo synthesis of prostaglandins. Yes, that's the concept of aspirin. It will decrease the synthesis of prostaglandins. Option D, antiplatelet effect of low dose aspirin is related to presystemic cyclooxanase inhibition. Yes, that is also a cyclooxanase inhibitor agent. So according to me, I feel like option B is the right option, guys. Okay, anyhow, we'll look into that. We'll move to the next question. A bigger question, I will mark it for later. A smaller question, I'm going to be trying it out. Okay. Which among the following drug is not considered as hit and run drug? Okay. Hit and run drug, what I know a mnemonic. MGRPA. MGRPA. M is for monoamine oxidase inhibitor. G is for guanethidine. R is for reserpine. P is for proton pump inhibitor. And A is for aspirin. Okay. With this knowledge, this question is, which of the following drug is not considered as hit and run drug? Which means this is a negative phase question, guys. Okay. Monoamine oxidase inhibitors, I know it's a hit and run drug. Omeprazole is proton pump inhibitor, it is a hit and run drug. Piroxicam is a non-steroidal anti-inflammatory drug. I think it will not be there. Aspirin, on the other hand, is there in that mnemonic. So according to me, piroxicam is going to be the answer for this question, because this question is a negative phase question. Dr. Yogita, here, as I've told, discussion will be happening separately, guys, because this is just how we are going to be solving that question within that time limit. See, as we can see here, the time limit is just 16 minutes more. So we are going to be doing how a question is going to be solved. That's it. I'm not going to be discussing that. Discussion will be happening after this test has been happened. Okay, the next question. Yes, I think I can attempt this question, guys. A 65-year-old elderly male was prescribed indomethacin for high-grade fever and later followed by a significant CNS adverse effect. Indomethacin and CNS adverse effect. Which among the following is the most frequent CNS adverse effect? So indomethacin and CNS adverse effect. That's the question here. Is it dizziness? I think it's going to be frontal headache, guys. It's again a one-liner question. The question appears bigger, but it's actually a one-liner. Which of the following is the most common adverse effect of indomethacin? Frontal headache. That's the reason usually indomethacin is not preferred to be given for headaches, guys. Not usually preferred to be given for migraine or any other headache-related conditions. Okay, with this, we'll click on to the next question. A bigger question, I will choose it for later. I will mark it for later. Bigger question, I will mark it for later. Again, a bigger question, I will mark it for later. a somewhat smaller question. I will try to attempt it. A 56-year-old female patient with risk of developing deep vein thrombosis was started on warfarin. Okay, first one, patient is a female. Second, the patient is on warfarin. She also has acid peptic disease. Which amongst the following proton pump inhibitors would be least appropriate? Okay, so they are asking about, this is a question regarding drug interaction between warfarin and one of the following drugs, which might worsen the warfarin's toxicity. The answer for this question is, I feel like it's going to be omeprazole, guys. Yes, it's going to be omeprazole, because omeprazole is a microsomal enzyme inhibitor, because I know warfarin is metabolized by microsomal enzymes. So omeprazole will tend to inhibit it, causing warfarin toxicity. So I think out of all these four options, omeprazole has got more interactions, guys. Well, okay, this is a bigger question. I will mark it for later. And this is again a bigger question. I will mark it for later. Now these are the questions which I have marked for later. The green ones are the answered ones, whereas the purple ones are the marked for later. I will go with the purple one first. I will go with the purple ones. Okay, we'll go back. Question number 2. Yeah. Again, we have a bigger, let's start how to discuss a bigger question, guys. When you come across a bigger question, as I've told in the first few minutes of the sessions, I will look into the last line. That last line is going to be the, how much time do I have left? Okay, 13 minutes. Okay, 13 minutes, and I have how many questions to be answered? I have 13 questions. Oh my God, I am just have a minimal amount of time to answer those 13 questions. Okay. Okay, so I'm going to be looking at the last line, guys. Which of the following drug is likely to be responsible? That's the question. This is a question regarding which of the following is going to be the cause of it. Triamterene, atenolol, clarithromycin, potassium chloride. I couldn't narrow down which system this question belongs to. I will try it out. Let's start with the first line. A 36-year-old patient with a recent history of heart failure was put on digoxin and had a level of 1 nanogram per ml. He was receiving, this is a PYQ, guys. He was receiving several other drugs, and later he presented with flattening of T waves with raised plasma level of digoxin. Okay, previously digoxin was very much low, and they gave one more drug. Now the digoxin levels is going to be raised up. So which drug tend to rise up the digoxin levels? Digoxin has got a famous interaction with P-glycoprotein inhibitors. P-glycoprotein inhibitors will tend to increase the plasma concentration of digoxin. Out of all this, the P-glycoprotein inhibitor agent here is clarithromycin. Because P-glycoprotein inhibitors, I remember a mnemonic called as vaccine drugs: verapamil, amiodarone, cyclosporin, itraconazole, nifedipine, erythromycin, and clarithromycin. So clarithromycin is a P-glycoprotein inhibitor which will increase the serum concentrations. So I feel clarithromycin is the answer for this question. Okay, we'll move on to the next one, guys. Next one is 8th question. Okay, I've clicked on to the 8th question. Let's look into what exactly is the 8th question. I will look into the last line. What exactly is the last line? Which of the following group of drugs is most likely to be ingested, which is responsible for the symptoms of the child? This is a toxicity question. Okay. Anticholinergic, sympathomimetic, opioid, and benzodiazepines. I will look into that questions now. A 11-year-old child brought to the emergency department with the history of ingestion of unknown plant, developed mydriasis, okay, tachycardia, dry mouth. Good, beautiful. That's the clincher there. Dry mouth and warm skin. That means it's going to be an anticholinergic agent. That's the clincher terminology. When you come across this terminology, you have to think about anticholinergics. Well, that is the answer for this question. Very much direct, guys. Okay. The next one is, I think, in the right side, we can see the 9th question. I'm going to be clicking on the 9th question. Let's look into that question. It's a bigger question. I'm going to be reading the last or lead-in statement. Which of the following can be considered in this patient that can ameliorate the adverse effect? Okay. To ameliorate the adverse effects. Terazosin, silodosin, doxazosin, none of the above. All of the options are alpha blockers. I have read that topic. I'm going to be attending that question. A 78-year-old male patient with history of benign prostatic hypertrophy, BPH patient, was initiated with prazosin a week back by his physician. He was under prazosin. After taking the prescribed medicine, the patient does not want to take the medicine because of severe dizziness, which is interfering with his work, and the patient also had a fainting episode while getting up from the bed. This is what, guys, prazosin induced postural hypotension, or the first dose phenomena. So I have to check up a drug. Again, I will look into that last line. Which of the following can be considered in the patient that can prevent this orthostatic or postural hypotension? I have to choose a drug which has got least blood vessel activity, and silodosin is that drug, because all the zosin drugs will be having blood vessel. Losin and dosin drugs will not be having any blood vessel activity. So I feel that is going to be the answer. Okay, time is just 9 minutes more. I will go through the 10th question, a bigger question. And what is the lead-in statement? Which of the following is the most probable drug responsible for acute asthmatic attack? From that itself, I could have narrowed down timolol or latanoprost, because both might be producing that. But again, timolol, bitoxolol, latanoprost, and bimatoprost, all these are drugs used for glaucoma, guys. I have read that topic. A 45-year-old female patient went for regular eye checkup to ophthalmologist, diagnosed of having glaucoma. She was later prescribed some medication for the same. Afterwards, she was brought to the casualty with acute bronchial asthma. That's it. So anti-glaucoma drug, worsening bronchial asthma, timolol, beta blockers. Let's move to the next question. A bigger question, guys, a bigger question. Okay, last line. Which of the following is the most common reason for discontinuation of muscarinic antagonist in patients with overactive bladder? Okay, most common cause of discontinuation of anticholinergic in patients with overactive bladder. See, this question, this line itself is a direct question. There is no need to go above, because the last line itself is the direct question. Xerostomia, dry mouth, blurred vision, constipation, dyspepsia. All of this can be seen. Most common, I can narrow down to xerostomia, or I can narrow down to constipation, because CNS adverse effects mostly is going to be constipation. This patient, okay, doesn't have any CNS related conditions. So I think I will go with xerostomia. I will go with the dry mouth. I'm a little bit skeptical on this question. Again, we'll just look into that later. Okay, 13th question. Again, a longer question, guys, a longer question. Which of the following anti-rheumatoid arthritis drug require liver function test before starting of treatment? That's it. Question is direct, guys. The answer is methotrexate, because methotrexate is highly associated with hepatotoxicity. This patient is suffering from anti-rheumatoid arthritis, drug requiring liver function test. And that's it. It's going to be methotrexate. No worry in it. I will move to the next question. 14th question, guys. Which of the, okay, I will look into the last line. Which of the following agent for rheumatoid arthritis competes with CD28, okay, to prevent full T cell activation? The answer is abatacept, guys. Why? Because the sarilumab or golimumab or adalimumab, all the other options are targeting TNF alpha and other interleukins. Yes, this is not going to be affecting that, because this is CD28. Yes, I have reconfirmed it. This is a CD28 drug. That's going to be abatacept. Okay, I will move to the 15th question. Okay, 15, 1, 2, 3, 4, 5, 6 questions are there in 7 minutes. Okay, I will just try to hustle up. Which of the following is the most, okay, again, as usual, when you come across a bigger question, I will look into the last line. Which of the following is the most appropriate drug that would target the cause of his acute gout attacks? Okay, the options are allopurinol, febuxostat, probenecid, and pegloticase. Okay, I will go back to the question. I'm a little bit doubtful with the question. I will start with the first line. A 54-year-old man presented to the medicine department with the history of gout attacks and is found to have an issue with renal excretion of uric acid. That's the clincher terminology. Renal excretion of uric acid itself is going to be uricose uric agent. The answer is probenecid. Probenecid is the answer. I will move to the next question, guys. 17th question. 17th question. Okay, this question is very much smaller, so I will start with the first line. A 49-year-old male patient with history of rheumatoid arthritis was stabilized by his physician on a high-dose acetyl salicylic acid, which is aspirin. Which of the following is the most appropriate acid-base disturbance caused by the therapeutic dose of aspirin? So this question is regarding acid-base imbalance associated with aspirin. Aspirin is an acetyl salicylic acid. It is an acidic drug. It produces metabolic or renal acidosis and respiratory alkalosis. Because it's going to be increasing the breath, it's going to be stimulating the respiration. I can expect respiratory alkalosis to be developed. So respiratory alkalosis is there in option A and in option D. Option B says acidosis. Option C says acidosis is ruled out. A or D, Compensatory renal acidosis, I feel like this is going to be the answer for this question, guys. Option A is going to be the answer. I will move to the next question. Again, this is like a smaller question. I don't know why I missed it. Okay, I will start with the first line. A 70-year-old man, elderly individual, was administered penicillin. Good. Within 5 minutes of giving penicillin, he developed generalized urticaria, swelling of lips, hypotension, bronchospasm. This is penicillin-induced allergic reactions or penicillin-induced anaphylaxis. This patient is having swelling of lips, so it might be angioedema. Which amongst the following is the most appropriate first-line drug choice for him? So angioedema has to be treated with what? Yes, I have to go with epinephrine injection, guys. Chlorpheniramine, high-dose corticosteroid, nebulized salbutamol. None of these are going to be useful because this patient is suffering from swelling of lips, bronchospasm. We might lose the patient. I have to immediately treat the patient by giving epinephrine. Okay, I will move to the next question. 21st question. This is a somewhat bigger question, guys. I will look into the last line of the question. Which of the following proton pump inhibitor can be safely given in this patient? So this is a positive phase question, which has to be given. That's the question here. Omeprazole, lansoprazole, esomeprazole, and rabeprazole. Okay, I will look into that question here. A 65-year-old male patient with history of ongoing treatment for tuberculosis. Okay, anti-TB drugs present to the medicine department with complaints of heartburn, abdominal fullness, belching, later diagnosed having GERD. Which of the following proton inhibitor can be safely given in this patient? So this is not regarding drug of choice, guys. This is a question regarding drug interaction. Yes, this is a question regarding drug interaction. So they have asked which can be safely administered because tuberculosis anti-tubercular drug, I have to give a safer drug which has got very minimal interaction with the microsomal enzymes. Among microsomal enzymes, I have two options, rabeprazole or pantoprazole. I'm glad that rabeprazole is there because if pantoprazole is there, this would have been a confusive or a tricky question. Here we have rabeprazole because this will have many minimal interactions. I hope that's going to be the answer for that question. Okay, moving on to 22nd. Okay, this is a bigger question. Time is, oh my God, I have 3 minutes more. Which of the following laxative could be responsible for the above condition? Okay, 77-year-old patient, weakness, tiredness, muscle cramps. ECG showed QT prolongation. Oh, okay. Flattening of T waves, occasional AV blocks, serum potassium was low, hypokalemia, bisacodyl. Okay, hypokalemia is going to be bisacodyl, guys, because that is mostly associated with potassium and the electrolyte abnormalities. Well, that I think is going to be the answer. I will move to 22nd question, which is bisacodyl. Okay, I think I have finished. 24th question. I will look into the first line because only 3 lines are there in the question. A 65-year-old male, elderly male, surgical OPD, complaints of acid reflux, burning epigastric pain. Later, he was diagnosed of having peptic ulcer and was prescribed ranitidine and sucralfate. Okay, in the morning hours. Why is this combination incorrect and irrational? Because the answer for this question is ranitidine combines with sucralfate, prevents its action. No, guys, see, sucralfate for producing its action, we need acidic pH. Ranitidine will prevent the acidic pH. So that's why it shouldn't be given. Option A, no. Combination of two drugs for serious adverse effects like granulocytis, no. Ranitidine increases gastric pH, so sucralfate not able to act. That is the answer for this question. Okay, 24th question is over. Moving on to the last question, 25th question. A 72-year-old man with hyperlipidemia and kidney insufficiency has been treated with high-intensity atorvastatin. So we have two comorbidities, elderly individual, hyperlipidemia and renal insufficiency. Treated with statin, LDL is a little bit on the normal level. Triglycerides are high, HDL is low. Okay, this patient wishes to add another agent for hyperlipidemia, which is the best option to address. I can opt for fenofibrate, but patient is having renal insufficiency, which means I cannot give that. I think niacin will be the answer because gemfibrozil I cannot give. Gemfibrozil shouldn't be given because it might worsen the myalgia and the rhabdomyocytis. Okay, with this, I think I have done all the questions. Yes, marked for review, and I have answered all the questions. All these things are there in green. Because I am discussing with you and putting up the options, I couldn't have enough amount of time. If I have done that, I think I would have 3 to 4 minutes of time or maximum 2 minutes of time. And I would have got time to go and take a look at it, guys. So I'm not going for the review. Yes, 5. because I always give a feedback, because this always has to be done. Okay, good, super. So we have 25 correct, 0 incorrect, and 0 skipped. Very good. So we have around 100 in pharmacology mini test. Yes, as per the score is concerned, we have got a good score. As we can see, +4 for the positives, -1 for the negatives. 25 into 4 and -1 is going to be for the negatives, guys. I'm looking at it just along with you. Don't feel like, okay, you might be putting a little bit wrongly, but we're not here to compare the marks here, right? We are just here to how to analyze those questions, how to assess those questions. That's it. Accuracy is going to be 100%. Your performance is better than 36% of your peers. Okay, I don't want to look at who exactly is that 64%, because I hate those guys. And average, like total time I've spent 29 minutes. Average time is 71 seconds per question, which is actually not up to the mark, because usually, according to me, I will spend a maximum of 40 seconds. 40 to 45 seconds is what the time which I have inside my mind. So based on you, why I'm saying that is this is a question regarding how I'm thinking of answering a question. So 40 to 45 seconds is my average time, and that is going to be done on a frequent basis. If I do the questions on a regular basis, I can move on with that. And okay, and I'll be going through the statistics. As per my statistics, I can see question number 2. All these questions, no, these are the time taken, guys, because this needs to be done, because we have to look into which question you have spent a more amount of time, and you have to know if you have spent more amount of time and whether you have come up with the right option or not, right? Because for some questions, when you spend a more amount of time, most commonly that is going to be there in red, right? Most commonly is going to be there in red. If it is there, then that means when you think more, when you think for a longer duration of time, there is more chance that you might land up in negatives in that question. So if you come across, if you are like that, if you come across that particular niche group of people, please try to make sure that when you spend too much amount of time, you are overthinking it, right? Try to understand this particular issue and go back and start doing GTs in a different terminology. Okay, then looks for the review. Let's go with the review. As we know, okay, question number 1 is going to be allosteric modulator, guys, because competitive inverse partial agonist is not going to be there. The next one is clarithromycin. Yes, we are right, the one which we have guessed, because it's a P-glycoprotein inhibitor. Vaccine was the mnemonic there. And decrease in Vmax, no, decreased Vmax, because it's a non-competitive inhibitor. Yes, and here is where the explanation is, where they have given about competitive, non-competitive, and as we can see, non-competitive, what will happen to Km here? I think it is given as unchanged. No, it should be unchanged. I think they have given Km is increased. Next question, natriuretic peptide receptor belongs to which of the following receptor? Receptor is guanylyl cyclase. The one which we have guessed is right. Yes, and ED50, yes. We were having a doubt on whether option B might be there. No, I think, oh no, this is not the question. Okay, proof of concept for a new drug is generally proven into the following: phase 2, because we know phase 1, phase 3, phase 4, it's not going to be involved. We have already proven that concept in phase 2, guys. A 45-year-old male, regarding glycopyrrolate to allay anxiety, we have ruled out all the options, so no worry in it, no doubts in it. Here, dry mouth and warm skin. No, yes, we came up with the clincher terminology. The answer for this question is anticholinergic agent. I hope that's been given. They have given one more mnemonic there, a newer mnemonic. For Dhatura is the mnemonic there. That's for anticholinergic drugs poisoning. I used to think of it as sludge BBB or dumbbells is there. No, for OPC poisoning, you remember that mnemonic, dumbbells, or sludge BBB mnemonic is there. No, I'll just remember a single mnemonic and I'll put opposite of it, right? Sludge BBB opposite or dumbbells opposite, and that's what the symptoms of anticholinergics. Sludge BBB or dumbbells mnemonic is for OPC. The opposite is for anticholinergic agents. That's how I remembered it. And this is the one, guys. Again, zosyn drugs are more prone to land up in postural hypotension. Silodosin is, as I've told, has got very minimal activity in blood vessels. So that's why that is going to be the answer. I'm glad that I'm one among the 39% who have put up the answers for that. Again, timolol, yes, beta blockers. I was having a doubt with the other ones. Betaxolol, even latanoprost. Yes, latanoprost does not precipitate bronchial asthma because latanoprost, as we can see here, option C. As we can see here, option C and D, latanoprost and bimatoprost are PGF2 alpha analogs and does not precipitate bronchial asthma because we administer it via topical route. There will be very minimal systemic absorption, guys. Betoxolol, on the other hand, is a beta 1 selective blocker used in glaucoma. It has low propensity to produce bronchial asthma. The one which I have guessed, good. Yes, here I was having a confusion, guys. Xerostomia or constipation. Glad that I went up with xerostomia. Here, xerostomia is the most common reason for discontinuation of muscarinic antagonist in overactive bladder. Well, that's why I hope that that was the question which I was having a little bit doubtful, because whether it is going to be constipation or xerostomia. Here, anticholinergics can precipitate glaucoma. Yes, this is so direct. All the other options are bullshit options. And regarding this, what is the liver impairment? Yes, methotrexate. Methotrexate produces more hepatotoxicity. Methotrexate is associated with more hepatotoxicity, guys. Yes. Here, abatacept CD20H, no doubt, no worries or no doubts in it. Here, uric agent. Again, I was having a small doubt whether it might be pegloticase or probenecid, but probenecid is going to be there because it is not primarily based on renal excretion of uric acid. Pegloticase is not primarily based on renal excretion. It will convert uric acid to a water-soluble allantoin. That's how it's going. The excretion is going to be happening. Here, probenecid is primarily dependent on kidney's ability to throw the uric acid out. So, okay. I hope that the one which we have thought is right. Which of the following statements is least correct regarding the given NSAIDs? Yes, the one which I have told, aspirin zero water kinetics, guys. Yes, that's good. 48. Oh, this is question number 16. Option D. Yes, Yogita, option D, antiplatelet effect of low dose aspirin is related to pre-systemic cyclooxygenase inhibition. Yes, because cyclooxygenase type 1 is getting inhibited. Well, that's the mechanism of low dose aspirin, and that's how it is going to be utilized for an antiplatelet drug, Yogita. Well, that's why that's going to be a true statement. That's a true statement. It's not a false statement. It's a true statement. So they have asked about which of the following is false. It's a negative phase question, remember? So negative phase, I will go for option B. Good. And this is simple. This is aspirin, guys. Aspirin is going to be producing alkalosis and compensatory renal acidosis. Hit and run drug, this that we have no doubts in it, MGRPA. Yes, indomethacin headache. Well, that's the reason why we don't give indomethacin for headaches. Then what is this? This is penicillin allergic reactions, penicillin anaphylaxis, and how we are going to be treating it, epinephrine. And this question is regarding GERD and which of the following can be safely given. Okay, GERD and tuberculosis safe to be given. Okay, no drug interactions, rabiprazole. I hope you're looking at how we are doing it right now, my dears. Well, that's how you are going to be doing it. That's how you are going to be doing it even for your exams, guys. How to revise those questions, how to come up with those questions again. That's how the same thing we're going to be doing. And again, we have, this is the one which we have completed. Yes, this is hypokalemia, bisacodyl. We have confirmed it. I will reconfirm it. Which of the following laxative could be responsible for the above condition? Yes, we have confirmed it. And again, we have warfarin, metabolism, omeprazole, no worry in it. Ranitidine increases gastric pH. Why this combination is incorrect and irrational? Yes, I have reconfirmed that that is the correct answer. And which are the best option address the hyperlipidemia? Fenofibrate or niacin? I'm having a confusion, but renal insufficiency is there. Well, that's why I think they have given it in that. Yeah, see here they have given it in the options itself. Fibrates, fenofibrate, gemfibrozil should not be used due to history of renal insufficiency. But that's why we're not going to be utilizing this drug in that. So with this, we have completed this question discussion, buddy. Not exactly test and discussion. This regarding how we are going to be approaching, how I am approaching that question. We have lots of rules and regulations to make sure that I'm completing that question within that time period of within that 40 minutes or 25 minutes of time period. So I hope it's going to be, it was useful for you. We'll be discussing more, a very good session. We'll be having it more, and we'll come up with one more mini test, and let's see how that's going to be progressing up. All the best, and I hope that is going to be useful for you, and we'll meet up in one more session. Bye-bye.
Thank you. Thank you so much, sir, for your insights. I think a lot of people would have benefited from the kind of insights you gave. In fact, I was going through your procedure. When it's a large, long question, read the leading statement, then read the options to, bring it down to the family of drugs or the family of uh,
Yes,
the
the
drugs.
subject or the
Yeah,
system of the question. Yes.
and the system of the question. I think that that is a great way to go ahead and look at a question and analyze what is happening in that. Thank you so much for your time today, sir.
Thank you so
Uh,
much.
yeah. So, guys, if you liked it, please like the session, share it with your friends. Let them also know that something like this is happening on Doc Tutorials. Also, leave in comments what other kind of sessions you want us to bring in the days to come. Tomorrow at 10 o'clock, we will be exactly 6 months away from NEET PG's tentative announced date. And tomorrow, Dr. Raju Dhawan, Dr. Sandeep Sharma, and Dr. Swati will be available on our YouTube channel live, taking you through the strategies for time management, your preparation plan, your revision, your testing, what all things have to be planned over the next 6 months for you to be able to crack NEET PG with flying colors. Catch us tomorrow again at 10 o'clock on YouTube live. Again, this think like a mentor is going to be a session of is going to be a series of sessions. Last week we had the first session by Dr. Sandeep Sharma. If you have missed it, go back to that video that will be available in our previous live streams. Today we had Dr. Nileshraj. Next week we have Dr. Priyansh Jain taking up a mini test of biochemistry. So this is going to be a series of sessions. This was episode 2 today, and thank you so much for being a wonderful audience.